The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone, and thank you for joining us for tonight's webinar entitled The Impact of Dental Forces on Your Practice, Patients, and Production. This is part of the Aesthetic Masters webinar series, so please keep an eye out for other webinars by the Aesthetic Masters coming up in the next few months. My name is Scott, and I will be moderating tonight's webinar. Our presenter for tonight is Dr. Mark Montgomery. If you have any questions for Dr. Montgomery during the webinar, you can enter them in the questions portion of the webinar panel. We will be answering all questions at the end of tonight's webinar. So without further ado, I will now turn the time over to Dr. Mark Montgomery.
Good evening. Welcome, and I'm excited to spend some time with you over the next hour talking about forces in your dental practice, and specifically the kinds of forces that impact your patient's health and impact the dentistry that we do. So as you can see on the screen, I'm a dentist. I've been a general dentist since 1980. I've been involved with continuing education extensively, and I have an eclectic background of occlusion and force management, pain management, and orthodontics. I have been semi-retired from clinical practice since 2010, just a few years, and I'm spending the majority of my time right now working with dentists who are trying to improve the management of forces and force-related problems and sensory motor dysfunction in their practice. So welcome, and let's just jump right in and talk a little bit about what I think some of the challenges are that we're facing in dentistry. And I think that we see more and more a huge divide between patients who've done pretty well managing their dentition and those who have not. And we're seeing incredible impact of inflammatory disease and infectious disease. We're seeing more and more people, again, starting to move toward losing teeth and having dentures or overdentures and implant replacements for teeth that are being lost. And I think that for us as dentists, it would be in our best interest and in our patients' best interest to really figure out what kind of techniques we can use in our practice that can minimize future issues for our patients. You know, some of these downstream issues for us, some of these end-stage diseases, really could have the possibility of being mitigated by some attention to preventive care and better attention to what's going on with the function of the patient early. So what do we do to minimize long-term problems for our patients? And how does the dentist play a role in the management of pain and headaches? These, I think, will be two questions that we need to seriously consider during this next hour. In addition to that, we've got a huge role to play in managing increased costs of healthcare and help our patients become more wellness-oriented. And I think we need to think heavily about where our patients are turning for the treatment of head and neck injuries. Certainly we've been alerted more and more to the idea of traumatic brain injury, post-traumatic stress disorder, concussions in sports, and automobile accidents. And where do our patients turn to really get their system functioning normally again? And then as we think about the chronic pain that a lot of our patients are developing, how does that develop, and how does it make their general health deteriorate? How connected is chronic pain with disorders of brain chemistry like serotonin problems and depression, problems with anxiety, and problems with inactivity? So we have a huge role in working with our patients to try and help make their life better. And if we haven't really understood it yet, I think over the next 5 to 10 years, we are going to know more and more that the dentist's role in the primary care, the primary health care of our patients is going to increase dramatically. We see patients who walk into our practice all the time who have all kinds of malocclusions, who have had lots of dentistry done, maybe patients like this one who've spent thousands and thousands and thousands of dollars getting his crowns on his front teeth and root canals done, crowns and bridges in the back of his mouth and has never really addressed the underlying problem of the malocclusion. And that malocclusion, of course, continues to add forces with his deep bite and his abnormal chewing patterns, to the point that he's had root canal after root canal in the front of his mouth and apicoectomy after apicoectomy in the front of his mouth. Now he comes in and he's got a big dehiscence and a fistula over number 7, and when we start seeing the bone deteriorate at that level, when there is essentially no bone left on the facial of an anterior tooth, we're into a situation where we have a patient who has spent thousands of dollars and has been to the dentist regularly and yet continues to have these problems come up. And now he's looking at thousands and thousands of dollars again, because who among us wants to just go in and try to replace that one number 7 at this point when this entire system is under so much stress? So we see this all the time. And then we see these early problems. We see patients who come in, like this patient who comes in wanting to straighten her front teeth out a little bit, not really liking her gummy smile that much, but a lot of the problem with her smile is the fact that she has a lot more pink to white ratio than we would like to see. We'd certainly like to see more teeth in her smile, and we'd like to see her front teeth be not so crooked with her canines blocked out. But this patient, that's just the tip of the iceberg with this patient. That's what she wants. But what's really going on is that this woman has severe chronic daily headaches. She has headaches that are causing her to be in pain more than 15 days a month. And when half of your month is spent trying to cope with pain, your life is not as it should be. She has beautiful tooth anatomy in the back of her mouth. Yes, she has a narrow arch. Yes, her upper front teeth are tucked back behind her laterals. But she has beautiful, beautiful tooth anatomy, although she's already destroyed her lower first molars and has a crown on number 19 and a large filling on tooth number 30. But if we look at the incisal edges of her lower anteriors, she's already lost almost 2 millimeters of tooth structure off the edge of those front teeth. And if a tooth is normally 8 to 9 millimeters long and you've lost 2 millimeters off of that, you're in the 20 to 25% category, where that's how much enamel has been lost off her front teeth already at her young age. And she's a pain patient. And then we have patients who come in like this, patients who have dentin showing all over their mouth, who have broken edges, who've been to the dentist, who have had all kinds of abnormalities showing up. And really the best way for us to look at this is to say, how come all of this stuff is coming apart? And when it starts coming apart, I mean, we can see the exostosis on the maxilla here. I mean, we're seeing bulking up of bone, and it's totally related to the excess muscle activity that's being applied to this patient's teeth. That excess muscle activity, when it is in an unbalanced situation and causes overloaded reflex systems, then those forces that are being applied to the muscles must be absorbed and managed by the dentition and through the proprioception of the dentition. And the brain has very few options as to how to deal with overloaded forces. Generally speaking, the brain can make the forces worse and try and destroy these teeth that are getting in the way and things that are not aligned properly, or the brain can shift the focus to the muscles to try and avoid those problems. And as soon as it tries to avoid the issues of interferences or teeth that are too high or crowns that don't look like crowns, I mean, certainly in this photo here, we can just take a good look at tooth number 18's crown and compare it to the anatomy on tooth number 31, and it's not even close to the same. And so we really, as dentists, have to think about how are these forces being manifest on the patient's teeth, and where is this patient headed? Where is he destined? Certainly, we could rebuild everything, but that's a very expensive long-term project for the patient. And if we're going to be putting porcelain back in this patient's mouth, we can't absorb the kind of forces that he could with his enamel, and he's even shearing the enamel off. So we start to run into engineering problems right away. We try to over-engineer things as much as we can, but if we could actually control the forces and the function and the dysfunction that's present in our patient's mouth, perhaps they could better stand the treatment that we need to do. And when we look from an occlusal view, a lot more dentin showing, many millimeters of tooth structure that's been lost, enamel that's going to expose dentin and wear out 8 times faster than the enamel, and a multitude of problems with this patient long term, not the least of which is the fact that he has no more room for his tongue in the floor of his mouth. So all of these issues that we see every single day really add up to a decision that we need to make about how we're going to manage this patient's dentition. Now, in the past, we've taken a strong look at what we call occlusion. Essentially, where does the jaw belong and how do we fit the teeth together correctly, and can we indirectly get the muscles at a lower activity at rest and a more normal muscle activity during function. We can look at how this patient chews, whether or not they clench or grind, and we can look at all these different relationships of the teeth about basically how do the teeth fit together. But we must not look at how the teeth fit together in a vacuum. We must look deeper. We must think about how this patient works when they're functioning, because really the most basic occlusion principles not only include the comfort of the patient, but also how is the musculoskeletal balance. And that patient we just looked at, wow, so much muscle activity that we're actually increasing bone and creating exostosis around the teeth on the maxilla. Do we have beautiful normal tooth anatomy? In some of the teeth, they were not too bad, but a lot of them, they were destroyed. And the dentistry that we had done did not resemble the normal tooth anatomy in any way, shape, or form. We certainly didn't have an unhindered path to closure. This patient was having trouble chewing. The forces were very much unbalanced in that mouth, as even if we just looked from the front and we could see all of the enamel that was missing from the facial of the upper right side, and the enamel is present on the left side. We know that there are force imbalances in this patient's mouth. Is there good guidance? Is there a normal envelope of function? Or does this patient have to stress and strain just to chew food? And then what's the feedback system for this patient? Do their muscles, cheeks, face, teeth, all feed back into a sensory motor reflex loop that is positive for the patient or negative? And when it becomes negative, then we call that a dysfunctional pattern. So, stable mandibular position, a good goal for us. Normal disc apparatus and stability. When we can get normal discs, we love that. But in a lot of our patients, we see instability both in the disc apparatus and in the mandibular position and in the function of the mandible during chewing and swallowing. Once again, when we do major dentistry in a patient's mouth, these teeth have had to have root canals for a reason. And the reason is maybe some infection got in there, but likely there was overloaded forces on those teeth. And those teeth ended up becoming non-vital, requiring root canal treatment, and the teeth that were on the crowns underneath there fractured off and rebuilt with posts and crowns. And now we have, not only do we have the 2 teeth that we spent thousands of dollars rebuilding coming apart, but we also have the gum line around the other 2 crowns in the front that is highly inflamed and very much a part of an inflammatory stress-related system. Who among us really would want to go in, take those 2 teeth out, put in 2 implants and put 2 crowns on, knowing that we have not made any changes to the stress in the system that caused these things to come apart in the first place. It happens all the time. It happens when we do ceramics on the anterior of the mouth. We can put ceramics in, and you can see not only from the fracture line in tooth number 8, but also in the swollen and inflamed tissues that this patient is subjecting their mouth to a lot of force in the anterior region. So when we think about the forces that are going on in our practice, really the forces start in our patients' mouths. So the world of dentistry that we spend most of our time in and the treatment that we do for these patients is mostly focused on 3 things. It's focused on infection and acid and forces. And we have gotten very, very good at having conversations with our patient about infections. And we're getting even better at having conversations about the inflammation that's related to those infections and how that chronic low-grade infection can affect the overall health of our patient. But we also have gotten a little bit better at the idea that there are biofilms in the patient's mouth that are often acidic, and that the plaques that are around these teeth are not healthy for the teeth themselves. And so we see enamel that's eroded because of acid. But then we see all of these things like we've been looking at, which are a result of overloaded forces. Some of those forces are shearing forces, and some compressive, some friction like bruxism, and some abfractions from the bending forces that are placed on teeth, causing the enamel to microscopically abfract away at the gum line and create those wedge-shaped defects at the neck of the tooth. We deal with lots of other pathology in dentistry as well, including airway and skeletal developmental structural issues, oral cancers, and some of those certainly feed into these other 3 areas. But if we just thought about what the pathology is for our patients, most of the time we see tooth loss, it's a combination of 2 things. The reason we lose teeth is from infection and force, usually abnormal overloaded force that causes a tooth to break or split, a vertical fracture, or vertical periodontal defect. Enamel comes off the teeth primarily because of forces and acid, and it's usually a combination of those 2 things. The acid can come from a variety of sources, but when you put acid on a tooth at the same time as you stress it, those abfracted microscopic enamel rods are going to start to become eroded, and that erosion around the enamel is going to cause breakdown of these teeth. So if we know that most of this damage is done by infection and force and acid and force, why is it that we don't have a great communication system with our patient about the forces in their mouth that are causing these things to come apart? If we look at the tooth problems we see, tooth loss, tooth damage, parafunction, pain, range of motion disability, collapsing of the arches, all of these are force-related problems. And when I say forces, I mean the muscles of the patient are applying forces to the dentition through reflexes and through trauma that cause dysfunction in the patient's chewing system. So when these muscles are generating abnormal forces, because the muscles are adapting to an unbalanced foundation, then we're going to see all kinds of dysfunction in that patient. So whether it's from imbalance or sleep disturbances or reflex proprioception or injuries or pain, one thing we know for sure is that dysfunction almost always results in damage or disability or pain. So dysfunction is a concept of, do the muscles work the way they're supposed to work? And if they're not working correctly, what's causing them to work abnormally? Is it a reflex that's been changed? Is it a bump on a tooth that's in the wrong place, that the patient can't function normally unless that crown or filling is changed or adjusted back to normal. What is it, and how do we talk to our patients about the forces that are going on in their body that cause these teeth to come apart? Well, our best tool today is using the T-Scan software that tells us exactly where and how and when these forces are manifest on the patient's teeth and to what extent. And when we see the forces when we see the abnormal T-scan patterns, which measure the forces in between the teeth, we know, because of the research that's been done with muscle measurements, that whenever the teeth are out of balance, the muscles are out of balance. And the opposite is also true. If the muscles are not functioning correctly, the dentition cannot fit together properly. So what are the signs of this dysfunction? Well, it's all of these things that we treat as diseases all the time. It's just that we often treat these diseases at the site of the symptoms instead of treating these diseases at the site of the source of the problem. So how do we do it? Well, we need to control the muscle forces on these patients, and we need to control the force balance on the dentition. We're the only ones that can do this, because certainly there is no other healthcare professional out there who can manage the forces of the masticatory muscles and the head and neck muscles and the interdigitation of the teeth with regard to chewing function and swallowing function. We're the only ones. And if we're going to treat muscles, we need to be able to rehabilitate and restore normal function and normal range of motion if these patients are going to function normally. When that happens, we can reset engram patterns of pain and dysfunction and muscle reflex activity. We do it in a sequential way by balancing the muscles first, allowing the joints to come into symmetry, and then balancing the teeth and making sure that the reflex feedback loops are under control. So this problem exists not only on teeth, but real briefly, I just want to cruise through and let you know that this same problem of unbalanced forces causes patients to be in perpetual pain and headaches. Now, not all headaches are caused by the teeth. Not all headaches are caused by the muscles of mastication. But what we know for sure is that when patients have pain and headaches, it messes up our relationship with them. It makes them reluctant to get treated. They no-show. They don't respond well to local anesthetic. They're hypersensitive. They have increased compensatory muscle tension, either co-contraction of openers and closers or postural issues, and they end up with reduced mandibular range of motion. Where does that all come from? It comes from the same dysfunctional patterns, postural adaptation, and muscle activity in response to the dentition or in response to injury. And the neuroplastic adaptive changes that happen in the patient's brainstem will result in central sensitization and decreased inhibitory pathway effectiveness. Now, we used to not really understand how chronic pain happened, but the research that's been done over the last 10 to 15 years is really showing us not only the site of what's causing chronic pain to happen, but also how it happens. And one of my favorite researchers is Linda Watkins, and her group has spent a lot of time understanding what's going on with the neurons and what's going on with the glial cells that contribute to these pathological pain states the patients are in. Linda likes to give headaches to rats and then study the rats with migraines. And so it's a very is very interesting, the work that they've been doing with fMRIs and these brain stems on patients, on their patients who are actually lab animals. What we found as a result of their research is that all headache pain, including migraines, travels through the trigeminal nucleus in the brainstem. This trigeminal nucleus is what carries pain signals from C3 all the way through the head and neck, all the way up to the thalamus, and then out to the cortex where we perceive the pain. All the family of cranial nerves from the branchial arch all travel through this pathway. So the cranial nerve that we deal with all the time, cranial nerve 5 and 7 and 9, 10, and 11 all travel this pathway. And all of these cranial nerves contribute significantly in feedback loops with that headache center in a way that we know today that the dorsal horn of the spinal cord from C1, 2, and 3, even some from C4, but mostly C1, 2, and 3, contributes significant afferent input up through the trigeminal nucleus. And certainly all of the trigeminal nerves contribute to that. So if we want to get at the source or at the site that the Intel processor where pain is processed in the brainstem, we must go through the afferent sensory neurology of the head and neck. As dentists, we're the only ones that can do that. Pain patterns are memorized. Inflammation is a big problem, not just cardiovascularly, but also in the brainstem. Excess stress and excitatory neurotransmitters can result in increased pain patterns, and ultimately we get a decrease in downward inhibition of pain from the trigeminal nucleus because of the homeostatic mechanisms that control pain in that brainstem. I don't think I have to scare all of us too much with neurology, but we all know that in dental school and for many of us even beyond dental school, we spend a lot of time learning about the trigeminal system, everything from the trigeminal nucleus all the way, or trigeminal ganglion all the way up through the trigeminal nucleus, and that this center of reflex patterns of chewing and swallowing and functional muscle activity, bolus management, sleep management, breathing management, all comes through this one area. It's a highly innervated, intense nucleus in the brainstem that controls everything that we deal with every single day. There's been a lot of research done on the trigeminal system, and we know that from the work that's been done by Srinkath and others that there's a huge component of contribution from the glia and the neurons, which contributes heavily to migraine pathology. Watkins and her group have spent a lot of time learning about the role of pro-inflammatory cytokines that are produced by the glial cells in the trigeminal nucleus that result in headaches and migraines. And almost all chronic migraine patients have elevated cerebrospinal fluid tumor necrosis factor alpha levels, and that all of these syndromes are manifestations of central nervous system inflammation. So when we think about our overall wellness model for dentistry and helping patients to not have systemic inflammation, it behooves us to realize that what we are talking about is not just cardiovascular inflammatory problems, but also central nervous system problems. Chronic pain happens because the glial cells get switched on, and when they get switched on, they turn the volume up on pain. And the way they do that is by increasing neuronal activity when the brainstem cannot sense correctly what's going on in the body. That usually comes as a result of inflammation and stress and the use of pain-relieving agents like opioids. But even more importantly, trauma, scar tissue swelling, reduced range of motion in the musculature of our patients, whether that trauma was an elbow to the jaw playing basketball, or a soccer ball to the head, or whether it was a result of some minor incident that the patients had, that trauma to the head and neck region can end up turning the volume up on pain and making that patient go into a chronic pain state. So when we think about injuries to the head and neck, which contribute to this process, the injuries can be severe injuries, they can be mild to moderate injuries, and even here, like in the middle picture, women's soccer is one of the highest problems in sports. Young women have more neurological deficits as a result of soccer injuries than just about any other sport. And in the United States, everybody gets in a car accident about once every 8 years. If you haven't been in one for 24 years, that probably means that somebody else has had 3 more that you didn't get. So we know that these car accidents, big car accidents, and car accidents even as slow as 8 miles an hour can cause whiplash injuries that show up with MRI evidence of TMJ problems, whether it's internal derangements, inflammation, disc displacements, or degenerative joints. These subjects show up after an accident with abnormal MRIs. It doesn't take a very big accident to mess up your head and neck muscles. That sort of trauma to the head and neck is almost never treated. It's treated as if, oh, I took a bump to my head. And even if we sprain all the little tiny muscles in the head and neck that support our head on top of our spine, we usually don't treat that. Now, if it was an ankle or a knee or a shoulder that was sprained, believe you me, we're going to have some treatment for that, and we're going to be getting on that injury right away. But when it comes to the jaw and head and neck, we have not taken the same approach as medicine has for the rest of the body, and it's time that we start rethinking that. So what do we see as microtrauma? Microtrauma shows up on the dentition with some of the things we've already mentioned: lost teeth, wear on the incisal edges, breakdown of margins of restorations, inflammation periodontally, and dentin showing. When we have dentin showing on our patients, that means that there has been serious tooth loss, and that tooth loss is almost always a result of dysfunction, which could have been started by an injury, or it could have been started developmentally. Certainly when we have blocked out canines and division 2 centrals and narrow arches in the posterior with airway as another contributing factor, we know that these patients are dysfunctional. So this is how it shows up. It shows up to us clinically in the way where we can take a look at the cracks, fractures, defects, wear, range of motion, abnormal muscle function, abnormal pain processing, and abnormal TMJs. And if we just take all of this together as a comprehensive look at the sensory motor function of our patient, we will find that all of these issues end up causing the muscles to not work correctly. So whether it's an injury or whether it's an internal dysfunction of the patient, these need to be treated comprehensively in a way that we would expect medically, and not just dealing with the symptoms or at the site of the damage. It doesn't do us any good to just patch up teeth that are being destroyed by dysfunction, because when we do, we're going to build something else into that stressful dysfunctional system, and it will either likely fall apart, come apart, or we will unload it to the point where the forces are shifted to other areas of the mouth. And I think we've all seen patients who've had a tooth break this year and had a tooth break next year and a tooth break the next year, kind of the crown of the month club kind of cases, where It's just that every time we fix one thing, if everything else is not brought into balance, the problem is going to perpetuate somewhere else. So our management system must be to control inflammation, control muscles, control function, control these neurological reflexes that we see, and create an opportunity for healing for our patients. Our patients cannot get well if they do not sleep. And so many of our patients have sleep disorders, not just sleep apnea, but insomnias and parasomnias as a result of pain. And if we can't get our patients to sleep, it's very difficult to get them out of this chronic sympathetic tone where muscle activity is raised and we see bruxism, clenching, and damage to the teeth on a regular basis, in addition to the cellular physiology that gets dysfunctional with regard to the endothelium and nitric oxide balance, all the things that we see as a result of sleep physiology that get taken for granted instead of dealt with appropriately. We must get our patients an opportunity to heal. So when we talk about, or when I talk about rehabilitation, in the past we used to talk about full mouth rehabilitation like it was just rebuilding the whole arch. Well, for me now, it's no longer just a new jaw position or an occlusion design or a changed vertical dimension. It's not just muscle comfort, and I'm certainly not looking only at resting muscle activity. I want to look at functional muscle activity. So in order to rehabilitate somebody, we have to treat the tissue that's damaged. We have to get at the source of the problem. We have to restore force balance in the musculature and in the dentition. We have to reestablish normal range of motion for the muscles. We have to switch muscles on that are turned off because of dysfunction and spasms. And we need to take muscles that are hyperactive and get them back to normal, and muscles that are hypoactive we need to bring back up to normal so that we can reset the synaptic pathways. When we can reset the muscle activity of the patient, we can also reset the patient's pain and their reflexes. So the way we do it is we do physical therapy. We do physical therapy in the office, and we treat injuries and trauma, whether they're acute or chronic. And we treat these until the patient's musculature has been healed and is back in balance, where we can get strength of the openers that match the closers, where we can get the left side and the right side back to balance. And then we use personal home care systems for the patient so that they can manage their pain and manage their stress and can get their exercise and strengthen their muscles appropriately. And then we do force-managed dental therapy to recreate normal sensory motor pathways between the dentition and the brainstem and back to the musculature. So how do we do this? Well, we do this by combining physical medicine rehab with force-managed dentistry. In other words, we're going to do the rehab therapy in the practice, give the patient their home care. We're going to use an orthotic design to bring the patient back to symmetry, and then we are going to gradually and very slowly and conservatively balance the forces in the dentition. Before we do that, we certainly have to assess the functional physiology of the patient. We need to do a functional assessment, which includes a computerized range of motion scan for the patient's neck muscles. It includes a range of motion scan of the patient's mastication muscles, their opening, what's their maximum opening as a patient, what's their left and right lateral movement of their mandible. We need to look at patients' forces in their mouth when they're chewing, and if they're chewing on the left-hand side of their mouth and yet we still have a big green spike on the right-hand side of the mouth, we know that this patient, when they're chewing, they not only have serious working interferences on the left side, but we also have serious non-working or balancing interferences on the right side. These interferences feed back to dysfunctional patterns of chewing. So if we're going to treat Richard here, who comes in with that big hole in the front of his mouth, the first thing we have to know is that he's not going to save that tooth, of course, and we have to have an approach that's going to make sense for him. And the first thing that we have to do is we have to get his dentition set up for balance. So we need to treat his musculature in a way that can calm his musculature down until we can start to move the teeth to the place that we need to. So we're going to do some muscle rehabilitation therapy on him, and we're going to control his muscle engrams. We're going to reset the neurology. We're going to break any pain cycle that might be there and reestablish normal range of motion of his mandible. Then we have to take a look at what his vertical dimension should be, normalize the envelope of function, and control sleep disorders. So we're going to go back to our 4 elements, which we talked about, and we're going to treat like that. We're going to manage muscles through a combination of physical therapy modalities that we have fine-tuned the parameters and the protocols for the little tiny muscles of the head and neck, as opposed to using these modalities on extremities of the body like the arms and the legs and the shoulders and the hips. We're going to take the little tiny muscles of the head and neck and create appropriate amounts of energy that can assist these muscles to get back to normal function again. We're going to use microcurrent when we need to, microcurrent electrostimulation. We're going to use thermal modalities, low-level laser, exercise, functional work. We're going to use all of these elements to get our muscles and our forces back under control. Once they're balanced, once the forces are balanced left to right, and the muscles are balanced in closure and they're balanced at rest, then we can reestablish the range of motion. We certainly expect someone of this size to be able to open their mandible to 48 millimeters with a left and right movement of at least 12 millimeters each. So we're going to reestablish all of that first. And then once that's reestablished, then we're going to go in and we're going to move his teeth where they need to be moved, leave teeth alone where they need to be left alone. And in this particular case, we needed to do some in order to level this occlusal table and provide for normal function. We're going to have to level out his anteriors. We're going to confirm his TMJ condition with joint vibration, and we're going to either confirm or restore his posterior anatomy. In this case, we were going to be able to leave Richard's posterior anatomy alone. We're going to establish bilateral contact and bilateral forces, and then build the guidance that we need. So we're going to take a bite relationship, an indexed bite relationship, in a way that allows us to see, are we making progress with the joints? So we're going to take a joint vibration analysis that's going to improve from abnormal vibrations to a smooth closure pattern. We're going to take a bite relationship based on that index, and then we're going to prep and develop a new normal occlusion for this patient. We're going to work everything out in his temporaries, making sure that we have the guidance we need, that we have the function that we need, that we have the smile that he wants, and ultimately we're going to be able to provide that for him. So when we take forces into consideration and we create an unhindered path to closure, short occlusion times, good force balance, when we do that, we can see these abnormal muscles go from abnormal to normal, from high level to low level, and we can create an even force balance in these patients with normal muscle activity. We can do all of this if we pay attention to the forces that are causing these mouths to come apart in the first place. Where's the stress in the system? We've got to bring it to the middle. We've got to bring balance in time so this patient can have a short closure time, can be balanced left to right, and we can end up with a functional patient that doesn't have pain. So the way we create this today is that we have built a system that starts out these patients who are either in pain or in destruction. And we take these patients and we put them through a system of care depending on their level of analysis. But we're going to put them through a system of care that allows them to get better over a period of time. We know that it takes 6 to 8 weeks for muscles to heal. We know that it takes much longer than that for bone to heal, that it only takes a couple of weeks for skin to heal. And what we need to pay attention to is also that the brain chemistry needs to be managed. And in some of these patients, the brain chemistry actually is where we need to spend some time on the patient, because patients who are in the mode of dysfunction, patients who have dysfunction, we need to treat them as if they are anxious, depressed, insomniacs who have pain, because the same patterns exist in both of those patients. So we're going to take patients who need to have pain relief, and we're going to treat them for their pain. And as we treat them for their pain, we're also going to reestablish normal function for them in a way that we can stabilize their pathway forward. So when we think about patients who have destroyed dentitions, we know that we're the ones who can treat them. The question is, can we treat them in a way that it will hold and will put this patient back into a pattern of wellness, or are we just patching things up? And some patients need to be patched up for a little while, but sooner or later we have to get at the source of the problem if we're going to do the right thing for the patient. So my recommendation is that we not only treat the dysfunction that causes the teeth to fall apart, but we also treat the dysfunction that is at the heart of their headaches and their oral facial pain. And we treat both of these in a very similar way, where we rehabilitate the tissues that are abnormal, and then we can work on the teeth. If we want to treat patients who have headache pain or chronic oral facial pain, we must get at the source of the problem. We can't just continue to try and put drug band-aids on these patients, because as we all know, pretty soon those patients show up in our office and they say, I've been everywhere. I've tried everything. I've been to 6 different doctors. I've had CT scans and MRIs. They can't find anything wrong with my brain, but I have headaches every single week. And we're the only ones who can do something about that. Because when the functional physiology of the head and neck is involved, no one else can treat that. Nobody else can treat the muscles of mastication the way we can. Nobody else can treat the head and neck muscles the way that we can. And so if we think about this, if we take a natural, effective, conservative approach that supports all your other dentistry, we can start to get at the heart of these problems. We've been seeing, over the last 5 to 7 years, we have been seeing real headache relief on these patients that is almost unbelievable. We're seeing headache relief on people who've had chronic migraines for over 20 years. And now, instead of having 4 or 5 migraines a month that last 2 or 3 days, now they're having 1 migraine about every 6 to 8 months. 6 to 8 months. Not every month, but every 6 to 8 months. And they have 1 migraine, and now instead of it being a level 8 or a level 9 on the pain scale, it's 3 or 4. So when we can change the quality of someone's life that much, then we can help them spend time with their kids and go to their kids' Little League games and go to their daughter's weddings and go to their kids' graduations and go to their family reunions and spend time with their family in the evenings instead of holding themselves up in a dark room feeling guilty and frustrated because they aren't even part of their own life anymore. So I would encourage you to think through this force-related issue in a way that says, okay, so if we're seeing abnormal forces in our patients' dentitions, what does that do to our practice? If we have an opportunity to help people get better, and we're the ones who can do it, then we should take that opportunity. It will increase the number of patients who say, you have saved my life. You have made a huge difference. I don't know what I would have done if I hadn't come here. We recently saw a testimonial from a man who was suffering from trigeminal neuralgia and cluster headaches for years. He would wake up in the morning and lay in bed as long as he possibly could until he dragged himself out to his sofa and turned on the TV. And he laid there watching TV waiting to die. That's what he said. I didn't say that. He said, I just laid there waiting to die because the pain was so bad. He couldn't plan anything. He couldn't do anything. He couldn't go anywhere. He couldn't work anymore. And yet now he's back in the saddle. Now he's back. He can plan to go to the movies with his friends. In fact, he said, you know what? I even enjoy just going to the store now and walking around and shopping. He said, because I couldn't do that before. When you have people who are just in severe pain and nobody else can get at the heart of it, it's time for us to step up, I think, and say, really, is there something we can do to give our patients their life back? We've asked people if they've had headaches, but we haven't really delved into it because we haven't had a good answer up until now. But now we have some answers. We don't have the only answer. There's not only one way, and not all patients need what we do. But when we can do a functional assessment, find out where their deficits are, and help them to make a decision about what kind of treatment is going to help them move forward. Certainly some conservative, effective therapy at a dentist's office where we combine that with the dentistry we already know how to do, that's what makes a huge difference. And when we see patients with severe dental disease and it's really, really destroying their teeth, we really need to step back and say, what is wrong with the forces in this mouth? Where is the stress in this system that we need to resolve before we can move forward? And over the years, everything that we've done in occlusion has been change the jaw position and change the interdigitation of the teeth. And now I'm going to step out on a limb and say we've had a missing link, and that missing link was rehabilitating the musculature of this patient prior to doing their dentistry. And when we do that, we can be much more effective, not just at the headaches and pain, but also we can be much more effective at the long-term stability of the patient's dentition, which is really, that's the most effective treatment of all. So I want to say thank you very much for spending this time with me tonight, and I would encourage you, if you're interested in finding out about these therapy systems that we're using to help control forces in the patient's mouth, give TruDenta a call. It's been an amazing journey over the last 10 years, and we're seeing some incredible results. And I just hope that you will look into it. Thank you very much. Scott, are you still with us?
Yes, I'm still here. Thank you, Dr. Montgomery, for speaking with us this evening concerning dental forces in our practice. We will now open the floor for any questions. Doesn't look like we have any questions for you tonight, Dr. Montgomery.
All right. Well, this has been it's been a great time, and I think that that over the coming years we're going to get better and better at the comprehensive care of our patients, and certainly if we can not only look to treat these patients who are already at the end stage, but if we can look at these force-related systems and start to get patients in balance early, I think we can prevent a lot of the severe dentistry that we see these days. So hopefully we'll continue to move forward with our force management, and I just want to say thanks for having me tonight. Thank you to Aesthetic Masters and to TruDenta, and we will talk to you very soon.
Thank you, Dr. Montgomery, and thanks everyone for joining us tonight. Once again, look forward for additional webinars coming soon from TruDenta and Aesthetic Masters. Thank you, and have a good night.